Very good morning to everyone. My name is Dr. Sridhar. I am doing neurology residency in Sree Tirunal Institute of Medical College in Kerala. So my topic is seizure outcome in women of reproductive age after switching from the valproate. So in this study, we try to address the germane query of switching from valproate to other anti-seizure medications, especially in women with epilepsy. Whether scientifically is there any enough evidence to support it or not. So, as we all know, valproate is a time-tested, well-established drug, which is used as a drug of choice in many of the epilepsy subtypes, especially in IgE syndromes. Under this IgE syndrome, as we all know, it is one of the most common epilepsy syndrome in women of reproductive age group. But again, in women with epilepsy, especially during the pregnancy or when they're planning to conceive or before the marriage, towards the conceptual stage, uh, they tend to avoid the valproate because of the expected teratogenicity. But then various studies have looked into it and they have suggested that most of this teratogenic side effect from the valproate is due to the high dose in the anti-seizure therapy regimen. And then what they have given only thrust to the teratogenicity, which is incriminated mostly on the valproate. But then there are very few studies or registries in the world, right, which have looked into the aspect of losing the seizure control in the mother and their effect on the seizure. And most of the time, the practitioners and physicians, they have given only thrust to the fetal malformation rather than balancing between the fetal malformation and the maternal aspect of losing the seizure control and their subsequent complications. So we have tried to look into this aspect. As we all know, seizures in this quoted studies, seizures became more in frequency during pregnancy, especially when valproate is withdrawn, as shown in this particular studies. Especially the frequencies worsened from 15% up to 30%. That is, it has doubled in the frequency when they try to withdraw the valproate. So hence, to underscore the importance of this study, as we see here, GTCS are frequent, especially after withdrawing the valproate. So it is no longer justifiable to hold the idea that only the presence of valproate in the anti-seizure regimen is responsible for it. It is sole factor responsible for the increased risk of fetal malformation. As in the study done by Vazda et al., they have shown that even after excluding the valproate, the fetal malformation rates were similar in polytherapy patients who are exposed to anti-seizure medications other than the valproate also. So there is a trade-off between the fetal teratogenicity and the maternal risk of losing the seizure control, which can lead to the generalized tonic-clonic seizures or sudden unexpected death in epilepsy, or the effect of seizure in pregnant women with complicating the fetal effect also. So they are given only the whole thrust is given only to the fetal teratogenicity. Most of the time, they are not taking into the aspect of looking into the aspect of losing the maternal seizure control. So in our study, we try to look at the into this other arm, in particular, this looking into the maternal aspect of going out of seizure control, especially on withdrawing the valproate. And these changes were done because the women were expecting the pregnancy or they are reaching their reproductive age group. So our study is a single center study, but then nevertheless, our study maintains an exclusive registry for women with epilepsy for the past 3 decades or so. And though it is an observational retrospective analysis, the data are accrued from the prospective electronically maintained records. And a comparison was made between the seizure frequency while while they were on the valproate and then later when they were withdrawn or switched over to other alternative anti-seizure medications, especially because of the reproductive age group or impending pregnancy. So this is the flow chart in which shows we collected the data of women with epilepsy in the age group in the reproductive age group of 18 to 45 years, and we collected the data in both patients with primary generalized as well as focal epilepsy, and we studied the data in about 290 patients over the past 10 years. And then we excluded the patients who had epilepsy seizure control, which is uncontrolled while on valproate based anti-seizure medications, whether it is a monotherapy or duotherapy or polytherapy. And then we excluded the patients who were refractory to the medical management and who are requiring surgery, and then who had lost the follow-up or they are having inadequate follow-up data. And also we excluded the patients who in whom the valproate was initiated after the completion of the family. And also comorbidities such as maniac disorders or any bipolar disorders in women with epilepsy, where the usage of the valproate is mandated from the psychiatric perspective. So after excluding about 221 patients from the total of 290 patients, we had women with epilepsy, both of generalized and focal epilepsy, who are well controlled on the valproate. The total sample size in our cohort was 69. So coming to the results, coming to the epilepsy syndrome, the prototypical JME, which comprised of more than 40% of the patients in those patients who are well controlled on valproate. Other IgE subtypes totally they comprised around 83% of the patients, whereas about only 17% of the patients who are well controlled with epilepsy were consist of focal epilepsy. So coming to the dosages of valproate, daily dosages, when we looked into this chart as well as in the diagram, we can appreciate that about 26 patients, that is about 37% of the patients among the total cohort, they only required about more than 800 milligram per day, whereas about 65% of the patients, they required low dose, that is less than 800 milligram per day of valproate. And we all know the most of the studies have quoted that more than 700 to 800 milligram per day of valproate is the one which is having the maximum risk for teratogenicity. Now, when we looked into this issue of using the valproate using the alone or after switch polytherapy combination, here we can see about 51 patients, they were continued on the valproate after counseling the risk and benefits. About 18% of the patients were switched. Among the switched patients, the total number were 18. So when we compared this valproate group with that of the switch group, here we can see about 80 to close to 90% of the patients in the valproate group, they required only the monotherapy and duotherapy. Only 11% of the patients in the valproate group required polytherapy, that is more than or equal to 3 drugs. Whereas in the switch group, that is in the switch group where the valproate is switched into other anti-seizure medications, and if the patient is having further recurrences, they will be added further, dose will be increased or the newer drugs will be added. So in this switch group, among the total of 18 patients, more than 40% of the patients, that is more than 40% of the patients, they needed polytherapy to have the same level of seizure control as that of the valproate group. Whereas less number of patients were only in the monotherapy or duotherapy group. The same has been depicted in this figure. Here we can see in the valproate group, the most of the patients are in monotherapy or duotherapy, whereas only 10% of the patients were in the polytherapy group. Whereas in the switch group, maximum number of patients are in the polytherapy group when compared to the monotherapy and duotherapy. And also, when they switched into from the valproate to other anti-seizure medications, about 55 patients lost the seizure control. So that is amounting like a 10 out of 18 patients. So it is more than 50% of the women had lost the seizure control until they were requiring, until ultimately they end up in the polytherapy to have the same level of seizure control when they were in the valproate group. So then when we looked into the teratogenicity, which is the most dreaded and worst complication expected from the valproate, in the patients who were continued on the valproate, only 3 patients developed had a teratogenicity. And as we can see, one patient developed fetal valproate syndrome, and another patient developed neural tube defect, and another patient developed pentology of Fallot. But then, when we looked into the mean daily dosages of the valproate in these patients who developed teratogenicity, their daily dosage was more than 1100 milligram per day. So, as we already told, and also proven in many of the studies, more than 700 to 800 milligram per day of valproate is the one is going to have the high risk for the teratogenicity. That is again exemplified in our pointed out in our study. So here in our study, we have the patients who were, if well controlled on valproate, when they had when they were continued the high dose of valproate, about 4% of the patients developed teratogenicity, whereas after switching from the valproate to another anti-seizure medications, the maternal loss of seizure control happened in more than 50% of the patients, and they ultimately ended up in the polytherapy. So, based on our study results, we have to underscore the fact that maternal seizure control is as important as the fear of fetal teratogenicity or congenital malformations. Although only teratogenicity is emphasized in various studies and registries and in discussions. Unfortunately, valproate, which is a time-tested ideal drug for many of the epilepsy syndromes, the practice is to take out the valproate without giving much thought into the maternal loss of seizure control and the dreaded complications of this loss of seizure control, especially the pseudoepilepsy. So in our study, it is shown that switching from valproate to other anti-seizure medications leads to the polytherapy, and teratogenicity was observed only in the high dosages, high daily dosages, that is more than 1000 milligram per day. So coming to the strength and limitations, there are no there are not many number of studies or even registries over the world which are focused on this aspect of losing of seizure control, and thereafter the complications in women with epilepsy. So our study should pave the way to look into this aspect. Since already so much of data is available on the teratogenicity and fetal congenital malformations due to the valproate and its high dosages and all, which we again underscore is mainly related to the dose related. And the fact that which is the fact that which is this valproate is often misconceived, that higher dosages of valproate are unnecessarily given to the valproate women with epilepsy in the majority. And our only limitation is that we need large sample size and multi-centric study to prove the results better. So we conclude that in those women who are well controlled on low dose of valproate, that is less than 800 milligram per day, low dose of valproate daily dosages, if we switch them from the valproate to another anti-seizure medication just because they are planning for pregnancy or planning to conceive, that will lead to patients ending up in polypharmacy as well as losing the seizure control, which can complicated by SUDAP and recurrent GTCS and all. And again, when this loss of seizure control happens during the pregnancy, this again can lead to the fetal complications such as IUGR, fetal loss, abruption or abortion, organ malformation, or hypoxic injury to the developing fetus and all. So this is our we suggest switching from valproate low dose to alternate anti-seizure medication will lead to the higher more complications rather than the benefit. Thank you.